happy hour session today. We have a great topic ahead of us today, talking about higher BMI patients and hiatal hernia repairs and what do we do in what situation, what surgeries, and so forth. Before we talk about our speakers, we're going to talk about a few announcements. By the way, my co-host, Dr. Faiz Shariff, she is on the way. We will see if she makes it in time. But anyways, for our announcements, our annual meeting is going to be next month, June 15th to June 19th. Please join us in Washington, D.C. It's going to be a great session. There's going to be an opportunity where if you sign up, you can also go to Capitol Hill and try to advocate for a lot of our important causes on Capitol Hill, including getting better coverage for Medicare and Medicaid patients for all of our patients with obesity. Then for our other announcement, we do have the next fellow project happening in June 6th. It will be with Dr. El-Char and Dr. Hussein, and it will be about early and late complications of bariatric surgery. So please tune into that. Additionally, for all of the fellows that are on this call, I believe you were sent an email a few weeks ago about giving us feedback for all of our sessions that we have hosted for ASMBS, so including our fellow project, ASMBS Happy Hour, and the ASMBS Start program. So it's just a quick survey asking you about what times were most convenient for all of these sessions and what you took away that was most important from all of these sessions. It's a very quick survey, but if you're able to quickly answer it, it'll really help us make all of our programs much better for the future. So we'll also send that link very shortly. And then I believe that's all of our big announcement. For our speakers today, we have the amazing Dr. Maria Altieri. She is currently the section chief and director of bariatric surgery over at Pennsylvania Hospital with the University of Pennsylvania in Philadelphia. She completed her residency at SUNY Stony Brook, and then she did her fellowship in minimally invasive and bariatric surgery at the Washington University in St. Louis, Missouri. Dr. Altieri has great clinical interest, including our bariatric and minimally invasive surgery. She also presented at multiple national meetings, published multiple medical journals and book chapters in this entire field. And she also has a strong interest in graduate medical education, clinical outcomes research, and disparities. She holds a lot of leadership positions in several of our major organizations, including the ACS, SAGES, SSAT, Association of Women Surgeons, and so forth. She is a big member of our society, and we're so glad that she is here to talk to us today. And to introduce her, we also have Dr. Suraj Panjwani. Let me pull up your bio. Okay, Dr. Panjwani was born and brought up in Mumbai, India. He got his medical degree from Grant Government Medical College and Sir J.J. Haas Group of Hospitals. He did his general surgery residency at St. Mary's Hospital. It's an affiliate of Yale University in Waterbury, Connecticut. And now he's doing his MIS Bariatric Surgery Fellowship at Advanced Laparoscopic Surgery Associates in Fresno, California. So thank you for joining us today. And please, if you're able to share your slides.
All right. Good evening. Thank you for this wonderful opportunity. I'll get started. I have no disclosures. So speaking about the topic itself, hiatal hernias are commonly seen in patients with morbid obesity. The incidence is about 2 or 3 times higher due to the increased intra-abdominal pressure. Majority of these hernias are of the sliding variety, and they are frequently encountered during bariatric surgeries. GERD can be troublesome for patients who have had a sleeve warranting reintervention or a conversion in some situations. Current guidelines are to repair a concomitant hiatal hernia during bariatric surgery itself. Hiatal hernias can be diagnosed on preoperative workup, either with the help of an upper GI study or an upper endoscopy. Manometry is also an alternative study. And in some situations, hiatal hernias can be found intraoperatively despite having negative preoperative imaging. Fixing a hiatal hernia does reestablish the anti-reflux mechanism by restoring the angle of his and the intra-abdominal position of the LES. Often the sleeve or gastric pouch are at risk for migration due to a hiatal hernia. And hiatal hernias can also become bigger with weight loss, especially when the fat around the GE junction also is lost over time. However, concurrent repair is not without complications. There can be complications such as bleeding, infection, or even adhesions in the long term. And it can be somewhat challenging to perform in patients with a higher BMI. Smaller ones can also be left alone, and ultimately, repair is something that is catered to patient suitability and surgeon experience as well. With that said, I wanted to share a few articles talking about concurrent hiatal hernia repairs with bariatric surgery. The first study is actually a systematic review and meta-analysis comprising of 17 studies. This included sleeves, gastric bypasses, and lap bands. Their main objective was to study pre- and post-operative GERD outcomes, as well as to understand the safety of performing a concurrent repair. They found that it was safe and effective to repair a hiatal hernia with all three primary bariatric operations. GERD after sleeve was reduced as a result of reduced gastric volume, quicker emptying, and also reduced acid production. After a band, the crural reinforcement resulted in an overall restoration of the anatomy and also prevented a gastric prolapse. The next study looked at long-term results. This was a retrospective single surgeon study, which included 91 patients. All patients underwent a workup to identify a hiatal hernia. In this study, crural approximation was done using 0 ethibond sutures. They used a 40 French for their sleeves, and about 20% of the repairs were done with pledgets. All of these patients had a 7-year follow-up, and GERD was the primary outcome of interest. This study divided their groups based on BMI with a cutoff of 50. It was very interesting to see that 60% of patients in each group were actually asymptomatic, and also in a lot of the patients, hiatal hernias were not found on preoperative imaging. 30% of the patients reported postoperative GERD. Approximately half of these were persistent GERD and half of these were new onset GERD. The rates were not different based on percent excess weight loss or the use of pledget. BMI also did not make a difference in those who recurred. What was interesting was that in all the patients who had a hiatal hernia recurrence after the operation, all patients had esophagitis, and one patient actually had Barrett's esophagus. One of the limitations of the study was that quite a few patients who were asymptomatic post-operatively did not get any imaging. Actually, they refused getting an upper GI or an endoscopy. And so the findings of esophagitis were probably underreported. In conclusion, they said that a concomitant repair should make you suspicious. A GERD after a concomitant repair should make you suspicious of a recurrence. The last study, this one also looked at outcomes. However, this was done using a nationwide health insurance claims data set. Patients who did and did not have a hiatal hernia repair during bariatric surgery were compared. incidence of postoperative interventions were studied, and these included endoscopies as well. It was found that patients who underwent a sleeve and a hiatal hernia repair required more operative interventions, whereas those who had a bypass did not. However, both groups required more endoscopies postoperatively, and revisions and conversions were rare in both the groups. In this study, there was no information regarding the size of the hernia or patient symptoms. As their conclusion, they said that sleeves with a hiatal hernia repair increased interventions postoperatively as compared to a bypass. In a way, it questions whether the safe sleeve is now a higher risk procedure. At our institute, we do fix hiatal hernias if one is found during the operation. I wanted to share some of the techniques that I have seen and learned as a part of fellowship. So the first video shows us approaching the hiatus from both sides. A liver retractor is placed in those patients who require a hiatal hernia repair. We start by dissecting the stomach along its greater curvature up to the angle of His. In all cases, we dissect until the left cruce is visualized. If a hiatal hernia is seen, the hernia sac dissection is usually attempted from the left side. Electrocautery is useful. Here, as you can see, clear contraction of the left crura. It helps to delineate the crura from the surrounding tissue, especially when sometimes the planes are not as clear. Other instruments, such as an ultrasonic scalpel, can also be used instead of a hook cautery. The dissection is carried out circumferentially. If need be, such as in this case, we also approached the hiatus from the right side. We started by opening up the hepatogastric ligament. We then dissected the sac off of the right cruce. Both blunt and sharp dissection is performed. Always being careful not to injure the vagus nerve. Once both crura are dissected, we ensure adequate intra-abdominal length. Hernia sac or a paraesophageal lipoma, if any, are resected. We then complete stapling or sleeve gastrectomy. And then perform our cruroplasty using non-absorbable interrupted sutures, such as a zero ethibond. Additional sutures are then placed either in a continuous or interrupted fashion to reinforce the phrenosophageal membrane, and an endoscopy is also performed to evaluate the sleeve and make sure that the hiatus coapts appropriately and that the closure is not too tight. In our second video, I wanted to show how both crura can be dissected from the left side alone in cases of a smaller hiatal hernia. We start by dissecting the left crus. And then using blunt dissection, we're able to see the other side as well. And once we have a good visualization of both crura, we then perform our cruroplasty and phrenosophageal membrane reinforcement as shown in the previous video.
Hey, Suraj, if I may, I just ask some questions at this point. Hi, guys. Sorry, I was a little late. Normally in my small town, there's no traffic, but we had some traffic jams, so I had to rush in here. Why are we only approaching it from the left side and not from the right side? Like, what is the advantage of doing that? Oh,
So I think in some situations, instead of opening up the hepatogastric ligament and opening the phrenosophageal membrane on the other side, you only divide one side. So you keep the integrity on the other side while trying to fix it from one side. So this way, you don't have to repair the phrenosophageal membrane from both sides instead of doing it from one side alone if it's a smaller hernia.
anyone else wants to chime in? Because I don't see the classically, we would want both the sides to be approached. If you're going to do it, you want to approach it from the both sides. So I just want to know what was the thought process. What exactly are you trying to preserve on the right side? It's a flimsy membrane of pars flaccida, right?
Yeah, it is. I don't know if you were able to see the first video as well. In the first video, I showed that usually we approach it from both sides, especially if the hernia is bigger. But in certain situations where it's a small defect where you can actually see both sides of the crura from one side alone, then it's possible. I mean, it's an option. The advantage that I understand is that you're not disrupting the phrenosophageal membrane on the other side and preserving one side compared to disrupting both sides.
Okay. Sorry, go ahead. I
Yeah.
just thought we'll make it a little bit more interactive,
Oh, no, absolutely.
especially when you're watching videos, when your thoughts come up,
Yeah, and I think that's a great question. Happy to hear what other
Yeah.
feel about that. It's a good learning
Okay.
In the
opportunity.
chat as well, by the way, there is a rule number 2 in ALSA.
Yeah.
Think about the next guy. If one side remains clean, good for the next guy. So I guess in terms of like recurrence rates and so forth, it's I guess a good point.
So then you know what, let's continue this and maybe we'll leave questions for the end.
Sure. So this is the last part anyways. In this last video, I actually wanted to depict how in some cases the greater curve dissection may actually be limited due to a hiatal hernia. In this, the greater momentum was incarcerated and needed to be reduced. In fact, in this particular patient, preoperative workup actually did not identify a hiatal hernia to begin with. So in this situation, an esophageal retractor actually comes in handy to reduce the hernia itself. And so then we reduce the hernia, we dissect the paraesophageal lipoma.
My God, it keeps going.
There's still more to come.
That must be very satisfying, by the way.
It was, that's why I kept it. I could have cropped it, but I felt like everyone needed to see that. So we then take the lipoma out. It's always important to not to amputate the lipoma too low, as well as the vagus nerve is usually at the base of the esophageal lipoma. And once we reduced it, then we were able to identify the crura appropriately and then close it like we usually do.
And what surgery were you doing here besides the paraesophageal?
This was a sleeve.
And for this one, you also didn't go through the right cruise, it looks like, right?
Yeah.
Yeah, this one was no, I
Maybe
think
we can.
went through this one. We probably went through. So,
And you're putting stitches on the anterior side and posterior side.
correct.
Okay.
So that's it. That's all that I had.
Awesome.
Thank you so much for giving me the opportunity to present.
Absolutely.
I'll stop sharing my screen.
Dr. Altieri, sorry, I was a little late, but I would love to have introduced you. She's the awesome program chair from SAGES here, a good friend.
Well, thanks, Faiz, and well, thanks, Dr. Shariff and Dr. Park, for the opportunity here. I've never been to a bariatric happy hour. I was assuming that there would be some liquor here or something.
Yeah, it's BOB. You bring your own one. By the way, I love the chair that you're sitting in.
Oh,
That
thank
is
you.
such a boss chair.
I used to be my husband's chair, but he doesn't use this this room anymore. So my chair, I use it a
The
lot.
chair. Absolutely.
TMI. Anyways, no, thank you. I think that was a great presentation, by the way, and thank you so much for sharing. And I just wanted to bring some points here and then kind of open it up and be a little bit more interactive. By the way, I saw a couple more people here, Dr. Gibbs and Dr. Wilson, so some other practicing surgeons. So it's great to see you guys. And I'd really love for this to be like more of a discussion rather than just me like kind of like
Absolutely.
over and over. But a couple of points I wanted to make. So just because of the concomitant findings of hiatal hernia and high BMIs, I was just wondering, what is the workup that all of us are taking? I can definitely give you like some of my workup. I mean, like when we see the patients, we kind of go over symptoms, if they're a sleeve or a bypass, depending on whatever they are, and whatever they have symptoms. I usually order like an upper GI versus just do my own EGDs, and just wondering what other people are doing out there. Whether there's any, you know, specific, placement, like, you know, like what kind of choices you make. My choice is usually an upper GI, if absolutely no symptoms. An EGD, like if they're asleep, for example, but an EGD if they are going for a Roux-en-Y gastric bypass, because I will also want to kind of check on that remnant and make sure that the remnant has no concerns, because I've found a couple of patients who had like a cancer in the remnant like years after. So just for like my sake of mind, but I'm just curious as like what other people are doing as well.
So Dr. Vakisha Wilson said if she does an EGD and upper GI, she wants to know how large this is. Dr. Park, you wanted to, what do you do in your practice?
Same thing, upper GI and EGD, but our EGDs go to our GI colleagues because that's just the way things are around here. So, but yes.
So I just see there are two Dr. Parks. I am Dr. Shariff, okay?
Yeah.
Just anyone wants to
Just
know.
use my link, so it's okay.
And sorry, my link, I didn't know where it was. So Juyeon had to send her link. That's why you see two Dr. Parks. In my case, I would love to do an endoscopy on all my patients. I don't know if you guys have, and anyone who's practicing have faced this. We can't get coverage for all endoscopies if there are no symptoms. So in those circumstances, what I do is I do an upper GI, and if they have symptoms, I go for an endoscopy. You want to know what's going on. So that's my workup, Dr. Altieri. Actually, Dr. Wilson actually does selective endoscopies. So, and Dr. Panda does all endos on all my patients. So my question to you guys is, don't you have issues with insurance coverage? Because I ran into issues with getting these endoscopies? Good to know, not yet.
Not
All right,
yet.
Dr. Altieri.
It's just you.
No, I had so I used to do everyone. I used to do an endoscopy on everyone, but honestly, it was such a, like a little bit of a delay. I also do at the time of endoscopy, I check for hiatal hernia, but I also do a test for H. pylori and
Yeah, same.
on everybody, right? But it was kind of prolonging the process, number one, and it was just, like kind of like of a delay of a process, and we were kind of like, well, does everybody need it? So as a practice, we decided that just people that are symptomatic with that were going for a sleeve or whether they were choosing the bypass. So we kind of tailored this to our practice.
So Dr. Boone does endoscopies. If insurance, we do it in the OR. So my question now is, okay, so you do an endoscopy. I mean, I don't want to cut on your time. Do you have you want to present something, or you just?
I don't have a presentation. It's more like kind of like a couple of points that I wanted to make.
Okay,
like
go ahead.
And recently, I actually had this presentation with Dr. Gibbs for the SSAT about the ideal procedure for BMI above 60. And so we had like another discussion, like bypass sleeve, a SADI,
Yeah, that's exactly what I was.
Yeah,
trying to
so
do
what is
that.
the ideal procedure? Now I can tell you what my personal is, just because if I have somebody with reflux and somebody with a hiatal hernia, and my personal experience with some of the patients that are coming in as a revision as well. I rarely offer sleeve for someone with a hiatal hernia, and the reason for that, I'll tell you, I have a video. Unfortunately, it doesn't load. I just checked it.
Yeah.
Park and I tried it before this, but it's a pretty large video, and somebody who presented with lots of reflux and sleeve, and the sleeve just got up there. I don't like, I have this feeling like sometimes they just slide up there and then they twist and cause a lot of reflux, and I had to go and revise that. So that was my video. Hopefully I can chop it up and then I can, if anybody's interested, I can send it to them. So that's my reasoning about sleeve and no hiatal hernia, concurrent hiatal hernia at the same time. And I warn my patients about it. My go-to might be like the bypass, to be honest with you. I know it's not ideal because if like somebody's BMI 50, 60, it's probably like, SADI or BPDDS, but then that SADI and BPDDS also have the sleeve there. And so I just want to hear about everybody else's experience and
Sure.
what your
Maybe,
thoughts.
and even in the audience, please chime in and let us know what you think, because the only reason I wanted this talk was because exactly for precisely the reason you said, what do you do in BMI 60? If you do a bypass, you're actually, even if you have longer limbs, Dr. Wilson, bypasses, you're not getting the BMIs down. In those circumstances, what do you do is what I wanted to assert, and like, what is the consensus? There's not a whole lot in the literature to say. And I'll tell you what my thought process is. I would give them a SADI in these circumstances. Any BMI greater than 55, I give them a SADI, repair if it's possible and it's feasible to repair it right then and there, then I would. But sometimes it's not. Then in those circumstances, I might get them back in 3 months at the same time when you're scanning the gallbladder to do a repair together. The reasoning is a SADI conversion to a bypass conversion, and I actually have a video, so we can play the video while we are doing this. It's easier than, say, a patient is not losing weight. It's like choosing between the two evils, right? Like you have obesity and you have acid reflux. If I get down the obesity, then I can always convert and convert to bypass. And I don't know if that's a reasonable thought process or not, but yeah, sleeve is not already will be the number one revision research. Yes, I agree with you, Dr. Boone. Sleeve is going to be the number one revisional cases.
And Dr. Shariff, what is your size of your sleeve if you're doing a sleeve as a first procedure?
40 French.
20 French.
Yeah.
Okay, so it's a pretty small.
Yeah. But if I'm doing a SADI, I would make it, I still use the 40 French VCG, but I stay like one stapler breadth away from that. So it kind of, in my head, it comes up to 50 French.
Okay.
And I'll share this. This is just because we all love to watch videos, and please, I think Dr. Park had some questions too. So Dr. Park, why don't you ask, and I'll upload those videos to play in the background.
Oh, yeah. One of my questions, let's see, was about medications. At what point for these higher BMI patients, are you even thinking about giving medications? Is it even useful in these higher BMI patients?
So I can
High
tell.
BMI and hiatal hernia, are you talking
Yeah.
about?
High BMI hiatal hernia, like these patients, like to try to help decrease their weight and then fix their hiatal hernia, or with the medications, or what is your thought process?
You mean like GLP-1s or okay. So for really super high BMIs, I'll actually start them on GLP-1 and potentially actually Zepbound probably. Just because he has a better efficacy. You know, the Wegovy is like what, like 50. Unfortunately, they were tested in like, you know, BMI 33 to 38. So you don't know the real, like, you know, effects of like really high, super high BMIs. I hope that there's some data soon, but so I'll try with Zepbound, and I have been really successful. We've tried, like, you know, like I don't have a goal, to be honest with you. Some people are like, you know, 10% of your weight, and let's see how we do. But I look for even like, you know, 30, 40 pounds. I'll be happy with that, just to decrease the weight so much. I have had a patient who started 597 and got down to 520 with Zepbound for 4 or 5 months of Zepbound, which he was really happy. And then he actually was really interested. He didn't have reflux or hiatal hernia, but he was interested in the bypass. That's what he chose, even after I was like kind of offer him a 2-stage procedure, sleeve, and then potentially like either SADI or DS. But he was just happy with the bypass. He did really well. Now the question is also, when do you restart those, or should you restart them afterwards? And I usually do it about 6 months after, but I see also how they're doing, because nothing is, you know, 100% risk-free. And I find it you know, like even the medications, once you stop them, you know, like if they decide to stop them, then they kind of rebound and gain some weight afterwards. So happy to hear what Dr. Shariff, any thoughts?
I actually haven't had great luck with placing patients on GLP-1s and getting their weight down. For that particular reason, there sometimes you just want to get their weight down so you can actually offer that hiatal hernia. So one, coverage is like 25% of the prescriptions I prescribe are covered, right? So they can't get those. And secondly, the weight loss takes months to happen. I have a patient who since Jan till now has only lost 20 pounds. And she wants to continue with medications. And these are patients who do not want to go for surgery. But I actually offer them surgeries. And like I said, if it's higher BMI, you just offer them, you put your ports, like for SADIs and DSS, you put a port lower. If I know there's a hiatal hernia, I'll just go a little bit higher and offer that surgery. Now, Dr. Boone has asked a question, and I'm going to ask you, Dr. Altieri. Why are the different bougie sizes for sleeve versus sleeve to SADI?
Well, for SADI, usually actually it's a larger sleeve. And for the usual, so I do, like, usually I do for sleeve, I'll do like a Vizigi of 40 French, so I am a little bit on the higher side, and then I actually for SADI I'll do what you're doing, Dr. Shariff. I'll actually do the 40, but I'll actually kind of stay on the side of it, so make it a little larger. And that's just because of the intake. Like for SADI, for example, and for BPDDS, I feel like, you know, nutrition, you have to provide so much protein, though I don't want to restrict them too much. What is everybody else's?
I mean, I do the same thing precisely, because for me, I tell the patient, like, if you're getting a sleeve, you need about 60 to 90 grams of proteins. And for SADI and DSS, it's supposed to be 90 grams of proteins. So if you give them a little bit bigger stomach, then they can get more proteins, is what I say. Yeah, so this is a case that I'm going to start playing this. This is a patient who had a SADI and then ended up having a hiatal hernia and bad acid reflux. And Dimitri was like 67 or something. And so just when I am about to sign the consent, she tells me she had a leak. So that's when you see that. You know, I knew that going up, there was going to be a lot of adhesions. And in these circumstances, I just thought, okay, we don't do a lot of these conversions. So I thought I'll share this while we're talking about this. Now, question is, for higher BMIs, would you feel like we should just do sleeves and then come back and see, because with sleeves, you're not burning bridges, you can convert them to SADIs or convert them to a bypass if they have bad acid reflux. What do you think?
Personally, if it's bad acid reflux, I'll convert them to a bypass. That's just because of like, I'm old school, trained by a lot of old school people. And that was the thought process that it's usually something that, the bypass was started as an anti-reflux procedure, and probably is the best one for anti-reflux. I also find it that like the bypass somehow kind of keeps that pouch down, and so it doesn't slip up.
Yeah.
But yeah. That's
So Dr. Boone, actually I wish we could have an interactive session here, because Dr. Boone is like, he said, I'm the old guy with the sleeve, who does the sleeve, but why not do a SADI instead? You get more weight loss, and then sometimes I feel like the weight loss is going to help. Sorry, what was that?
We can ask James to let him speak if you want. James.
I'm here. I'm sorry, I missed the name.
Dr. Boone, Keith Boone, can you let him?
And Dr. Gibbs too, and Dr. Wilson.
Just let everybody
Just
join.
everyone in. We can have a nice lively discussion here. So this is where at some point I thought initially I thought the hiatal hernia, like I scoped her in the OR again. Unfortunately, I don't have the pictures of my scopes. I thought the hiatal hernia was like 3 centimeters. Maybe I just leave that and I'll come down here. But then when I go and do an endoscopy, you can see how big the pouch is. I'm like, this is going to become a marginal ulcer. So I had to dissect. I was thinking if I stayed below the leak there, that'll help me. Welcome, Dr. Boone.
No, we've been doing this for 35 years, long before there was a sleeve and even before there was a band. And the larger weight loss in general, more recently, we lean towards a sleeve. But we do that because they will potentially need a SADI or a DS. If they have a sleeve and they have reflux, we're probably looking mostly for a gastric bypass, but it depends on the patient, of course. But yeah, so we occasionally do a DS or SADI as a primary procedure, but most of the time we do a sleeve because some patients do so well with the sleeve, they don't need the SADI or don't need the DS. So that's kind of the way we look at that.
Yeah. Well, Dr. Boone, my question to you then becomes like insurances. There are a lot of insurances that are like one bariatric surgery lifetime kind of procedure. And the reason I lean a little bit more towards SADIs is because, or DSs, is because precisely for insurance reasons, I can always get a reflux surgery covered, but not the SADI, not enough adequate weight loss.
That's a good point. But, you can work with the insurance companies and you can do a sleeve to a bypass for reflux, even if they don't need it for weight loss. And
Right.
so there's ways to work with the insurance on that. But yeah, I agree with you on that. It's a little bit of a challenge with the insurances. And of course, they try to make everything as an outpatient surgery. They try to make everything, or try not to pay for anything. So a little bit of a challenge.
Now, please, I wanted to make another point as well. I was kind of like jumping to another but what do you guys do about like, tiny little hiatal hernias, like heel grade 1 or 2 that you see on and so I used to be like so aggressive towards it, go and dissect and so forth. And now I'm like, okay, like no, like even
leave
if
them,
No, I agree. We're not near as aggressive as we used to be. Like I mentioned in my comment, we used to dissect out every single case. And we probably made more hiatal hernias than we actually truly had. And because then once you dissect it out, you're kind of required to fix it. But now we have some of the GI docs that in their pre-printed endoscopy reports say small hiatal hernia on retroflexion view on every single case. So what do you take from that? And we have some GI docs that say 1 centimeter hiatal hernia, and what do you take from that? So we look for it each time when we're in there for surgery, and we'll fix it if we see it. But in general, we don't go looking for it anymore like we used to.
Yeah, same here. I started chasing those and just be like, okay, like if I don't see it and if it's like tiny. Like the dissection more you create, even actually more space and more potential for like something to slip up there. So I haven't been aggressive.
And the other thing we found is if you have a hiatal hernia, 3 years after a sleeve and they're not a candidate for conversion to Roux-Y, insurance will pay for a hiatal hernia repair for reflux.
Right.
And what about mesh versus no mesh? Because I know that we had that discussion. So
now you're getting into a difficult decision or discussion. I only use mesh if the tissue is so bad that I can't pull it together.
Same.
And what mesh are you using, Doctor?
I use the BioA, which was the pre-cut. Yeah, and it works nice. Does it make a difference? It depends on which study you want to review.
Yeah, I have this, I have this discussion always with my patients specifically because, recurrence rates, I mean, like depending on what you get, like some of the studies, they're 1 to 3 and 1 to 1 in 5 will recur within 10 years, right? Like it's just the meta-analysis is like pretty bad. And then I also, quote the Oschlager paper with like the 2 years and the 5 year.
Yeah.
So, yeah. And so I'll be like, 2 years, we got very excited, but then like in 5 years, I've also been in so many revisions that I find that like if you place a mesh, it's so much like the scarring is so much more in the dissection and more difficult. So then,
I only place mesh if I have trouble putting tissue together, and that's usually your 80-year-old female, real thin tissue.
Just because the tissue is like so friable, you're like, this is not gonna hold. And I feel like the meshes are there to prevent acute recurrence and not so much like chronic ones. And you're right, like going back in those patients, it's like I had to take, someone had a FASMBS mesh, and I kind of, although it's supposed to be absorbable or delayed absorbable, it still was there after 3 years. So I don't know. I do use the BioA. Actually, no, I use the NFAR mesh, and I kind of very selectively use that. Let's hear from Dr. Gibbs and Dr. Wilson who are here.
Hi, good evening.
Hey.
So, yeah, in terms of the mesh conversation, I usually don't use mesh really unless it's in the case where I have trouble approximating the crura. Some people think it makes it harder for the next time your hernia is gonna need to be repaired if that ever happens, but I don't use it that often. May use some pledgets. I know that's controversial, or smaller pieces of mesh on the crura to reinforce it, but I don't use mesh often.
Dr. Gibbs?
Yeah, you don't have to look at new studies. I mean, some of the old studies show that the repairs on the giant paraesophageal hiatal hernias, 25% recurrence if you study everybody at 1 year. But only 5% of those are symptomatic. That's a little different population than we're talking about with the bariatric patient. But in general, you're not going to cure every hiatal hernia. It's not like an umbilical hernia we can close completely. Most of the recurrences are not true recurrences. They're progression of the disease because your repair is intact posteriorly. It's stretching out anteriorly, where we usually don't put stitches because it's pericardium.
Yeah. So
I agree with those comments. Definitely only use mesh when the tissue is not able to come together.
And what mesh are you using, Dr. Gibbs?
The BioA as well.
Okay. So this, let me just kind of fill you in what's happening here. So I'm trying to get this area here is where everything is stuck, like the corner of the sleeve, the proximal staple line, right? Like, and I'm like, okay, let me repair that hiatal hernia. I might be able to get some stomach. Very soon you'll see I'll have a gastrotomy on that side. Like I opened up the fistula, and in those circumstances, what do? Do you go straight for EJs? Do you preserve a little bit of stomach? So, you have 3 layers to stitch to and a serosa as opposed to the esophagus. Like, Here, you'll see it was super hard for me to come through this tissue. This was calcified tissue, and this is one thing that, what I find difficult with robot is that there is no instrument that kind of mimics a harmonic. So I wanted to know, for those who do the robotics, if you guys have found something like literally here, I'm just gnawing through the tissue there.
Have you tried using Synchroseal? I know it's a little better.
Synchroseal, the problem with Synchroseal is like, again, you're going to be gnawing that tissue. But then that's another thing that I thought I could use. So you can see in my arm 4, I have suction irrigation, and then here going between vessel sealer and a scissors.
I don't like the Synchroseal, I'm gonna say that.
Synchroseal, like I know a lot of like Dimitri Stephanides, he loves Synchroseal. I just feel like you have to jerk a little bit to kind of get the tissue off. So
Yeah.
I'm a vessel sealer. If I had a sole instrument, I think I'll be a vessel sealer. I feel like it's so versatile.
Yeah, no, I like the vessel sealer too. I mean, it's curious to see like the robotic platform that Ethicon is gonna come, because that's maybe they'll use your favorite harmonic. But vessel sealer is probably
Yeah.
most
And
ideal.
for you, what I want to know is EJ versus like a micro pouch. This turns out to be a micro pouch. You'll see in a minute.
I mean, I'll try to preserve as much as possible. So maybe a micro pouch and hopefully you still have the left gastric.
Yeah, I do have the left gastric, or one branch going to the left
Pouch.
gastric.
Yeah, and the smaller pouch. I mean, EJ is like, I don't know. It's
15% leak, 5 to
Exactly.
15% leak, right?
so
And then what do you do for like now the DI anastomosis? What do you do? Because not everyone preserves right gastrics. Do you just leave it, let it be, and then just do a bypass, or do you resect?
leave it be.
You
Well,
let it be?
Yeah.
In this case, I thought it looks like it's becoming blue, so I did. So here, I'm just gonna fast forward this. So I dissect all of this and then do a micro pouch here. You see, there's one blood vessel going here. I see that. There's one blood vessel. I promise you there is. That's my pouch.
Wow.
I know. So that where you first saw that, that's the G junction. So I did have some amount of pouch, like it's you'll see this what I did here. So that's where the G junction is. So I think 1 centimeter of the pouch is left, and because I had that fistula that was opening up, I put some stitches and then came through like the.
Now, you try to get some more esophagus and kind of bring that pouch down, like in
Yeah.
like esophagus did you get?
So this pouch was sitting comfortably, but then this was like really, this must be my smallest pouch I've ever made. Literally, this is a 34 French endoscope, and I'm coming there. Seems like it's okay. So I'll come there, and then what I did was, hold on, this is another thing that I wanted to ask. Okay, so the pouches, they're done. Okay. Going faster. It almost seems like it's not moving.
Oh, it's going.
Okay, there. So then, yeah, look, what do you do with that? You can't just leave that there, and there's no blood vessel. So I thought I'll dissect this. Initially, I thought I can come in through like that, but there was not. I was going to narrow this lumen, so I did a dissection. What would you guys do?
Did you do an ICG test and just see if there's a
On this one, there's no
Yeah.
blood supply to here. This
There's
thing.
not? Okay. Yeah, you resected then. Yeah.
Yeah. Because you can't save that. I can't sleeve the small bowel, right?
Yeah. No,
So I just do that anastomosis. So that's going to be a distal. So this patient ended up having 3 anastomoses: this ileoileostomy, gastrojejunostomy, and a JJ. And this is something that I here I'll show you. I sutured the whole staple line. I attached the whole small bowel to the staple line, and then I fixed this.
I'm laughing, Faiz, because I had one of the first first Roux-en-Y bypasses from somewhere in New York that were done lap, and then they came with like this perforation of the remnant like super high, and I had to do like a big like laparotomy, and they had 3 anastomosis, and I was like, why do they have 3 anastomosis? I was like, that doesn't make any sense. And it was like literally the first, I think she said that she was the second lap Roux-en-Y gastric bypass in New York City or something like that. I don't even know who.
Yeah.
I was like, wait, what just happened here? So I'm just laughing that she had also 3 anastomosis.
So suppose if I didn't have that leak, right? Now I had no option to because if I had to fix that hiatal hernia, I had to go through that leak tissue. But if I didn't have a leak and it was all kind of clean plates, would you try to salvage the SADI by just doing a hiatal hernia repair?
You can.
But would you?
What do you mean? Like whether like just to salvage the SADI, yeah.
And just do a hiatal hernia repair?
I mean, probably yes.
Okay. And have you done any mostly for gastroesophageal reflux disease, have you done Link's procedure?
No.
Okay. All right, let me go back to our guest panelists who we volunteered them. Dr. Gibbs, what would you, a patient with, say, a moderate size hiatal hernia, about at least greater than 6 or 7 centimeters, BMI 60 or 65, what are you going to do for those patients?
I'm going to refer them to Maria.
Thanks, I need more patience.
But your hands are tied and you have
generally I would definitely go with a bypass and a hiatal hernia repair.
For BMI greater than 65?
Yes, if the reflux is significant.
What if I'll throw a challenge. What about BMI 70, 75?
I don't think it's going to make that much of a difference. If reflux is part of the indication, if you're not, they have a hiatal hernia, they're not symptomatic, then you start thinking about other things that'll give you more of a malabsorptive opportunity to enhance the weight loss.
Dr. Boone.
Yeah, so for a BMI 60, 70, I would do a sleeve, and I'm talking from somebody that did bypasses when there only was a bypass. There's no band, there was no sleeve. So, but I would do a sleeve at this point for somebody of that size, realizing that a lot of reflux is related to the weight, but also because I have the option of converting it to a bypass later after they've lost a couple 100 pounds and still need a surgery or still need something for reflux. So yeah, on larger BMIs, I tend to do a sleeve, considering they will need something else later. And I let them know that up front.
And Dr. Wilson, what would you do?
Yeah, I mean, I think it's a challenge just because with the weight that hiatal hernia is coming right back, and especially with the sleeve, if it's temporizing, I think that's reasonable because it's going to go right back up into the chest. Also trying medications, trying to really get the BMI down ahead of time as much as possible. But you have to do what's feasible. Maybe BMI 70, maybe a bypass, maybe it doesn't reach. And so
That's my problem.
Yeah. Yeah, it's a difficult discussion because we did gastric bypasses on BMIs of 70 and 80 when sleeve wasn't really an option, band wasn't really an option, and so
how'd they do? Good weight loss? Decent?
It's hard to argue. They did fantastic. Yeah, I had one guy that lost over 300 pounds and said he was going to bronze his Levi's when he got down to 200 pounds, and he did, but it took 6 people to take his bronze Levi's out of his pickup. But very good results with the gastric bypass in the large patient, but it is a much more difficult operation. So I agree with that. So, and that is now why I would now do a sleeve first, and consider conversion to a Roux-Y later if they have reflux, or conversion to a SADI or DS if they need more weight loss.
Yeah.
Okay.
And it's a good point. I mean, like I do have a discussion with patients because I find it that even when patients have reflux and hiatal hernia, they're very resistant to actually choosing a bypass, just because they feel like it's such a more involved procedure, and there's potential like for them perceived risk, higher risk of complications. So I do have that discussion in terms of like their reflux worsening. Like studies have shown like 1/3 will get better. 1/3.
Yeah, well, they feel it's more drastic, and that's a true thing to consider or discuss with them. But some people think removing part of the stomach is more drastic. Some people think putting a piece of plastic around the stomach is more drastic. Some people think rearranging the intestine is more drastic. So you can argue all those directions. So, and I think we need to discuss all that with our patients.
So I think I'm the most aggressive then. I talk to them about SADI and and I feel like
no, you may be in the right position going to a SADI first, but in general, I would do a sleeve first and see if they need anything later. Some people are start at 600 pounds and are happy being at 300 pounds. Don't want a SADI.
Yeah. And I do think that that's the challenge, because most people don't have a SADI DS as part of their practice. The comfort level of most surgeons may not be there. That's why it's still not as commonly done. Becoming more popular, of course, with the robotic platform and more kind of opportunities to, teach and video reviews. But I think the majority of people, especially for a high BMI, won't have a one-stage SADI in their arsenal. And so I don't think that will be as common for most surgeons.
That's a very good point, Dr. Wilson.
Something else, and just a couple of points that I wanted to make. First of all, like it's like no one size fit at all, right? Like I mean, like brief is like so all of us like are doing different little things, but there's not like a correct answer in a way. Something else that I wanted to bring out to Dr. Wilson's point though is also the patient selection. It's so crucial. It's so crucial because if you do SADI or DS and those people are like not reliable, which some of my patients in Philadelphia unfortunately are. You are subjecting those patients to like some severe malnutrition, absorption of vitamins that can actually cause like pretty long-term damage. So that patient selection is
that goes without saying. Like if they can't take 90 grams of proteins and they're not going to take vitamins, that's automatically you're not going to give them that. In those circumstances, I agree with Dr. Bur. I'm going to be giving them a sleeve as opposed to just go straight for a bypass. But
the other thing you have to look at too is if somebody's had a sleeve and 10 years later they want a revision, but you haven't seen them for 10 years, that's not a candidate for a DS or a SADI because that's a nutritional issue. And if they haven't followed up for 10 years, you're really asking for trouble. So somebody has to really show that they're going to follow up routinely to be considered a good candidate for a DS or SADI, in my opinion.
I agree 100%. I think patient selection is 100%, like especially for these really malabsorptive procedures, it goes like without saying. That's the only thing that I kind of ask them. If you can't take vitamins for 3 or 4 times a day and you can't take 90 grams of proteins, I can't offer the surgery to you. So
yeah, some of our patients can't afford the vitamins.
That's true.
We in Central California with Dr. Panjwani, where we're at, 86% of our pay is government pay, Medicare or Medi-Cal, or which is Medicaid. And so a lot of patients can't afford vitamins, which is a real challenge.
Interesting. So Dr. Panjwani, I'm going to ask you now, you heard all the experts and thank you for all the guest experts to come in and talk to us. What would you do if I had to pose that question to you? BMI greater than 60 and a hiatal hernia.
Yeah, I think I've been trained and I resonate with Dr. Boone's thoughts on that. I would also offer the patient a sleeve, possibly a hiatal hernia repair at the same time, maybe fixes the current problem. They lose weight, probably the reflux gets better. If they need another intervention in the future, then they have options at that time, either just a hiatal hernia repair or conversion to a different operation depending on what their weight is. And also what their comorbidities are.
Dr. Park, we didn't hear your thoughts. I am so sorry.
Before, I would have said, I would have just done the bypass for anyone with a hiatal hernia, but you guys are swaying me the other way, So I think we probably still do a sleeve and then let them have more options in the future.
I think I'd like to throw in the new world of magnets. Is anyone looking into that?
Oh yes, we had and the bariatric this one we had Dr. Garnier coming in. Yes, it is super interesting. Dr. Garnier's magnetic anastomosis are delayed, so it's like bipartition kind of procedure that you can do, and you can't do a true SADI, but Dr. Teixeira's group and the group in Orlando can do immediate magnetic anastomosis, and that's pretty cool. It's actually on Surgeon if you want to watch that one. I had Dr. Helmut Billy and Dr. Galvo or Professor Galvo come and talk about that. So it should be available on Surgeon for that talk. It's very interesting. Yes, definitely looking into magnet. I think that's something that looks like it's going to be.
We've looked at that also, and there's some good advantages, I think. With the magnet that Dr. Garnier is looking at, it's not an immediate anastomosis. It's a down the road when everything is ischemic and falls apart, and then it's a great anastomosis. The other one that you were mentioning is the one that we've used, and it's an immediate anastomosis.
So you've tried that, Dr. Boone?
Like for a JJ, yeah, we've done that, and it works well.
Perfect.
It's a little bit of a challenge just because we're so hands-on and trying to move things around, and you got the techs in the room saying, "Don't touch it, don't do anything." but yeah, it actually works very well. So I think there is some future in the magnetic anastomosis.
And it looks so beautiful. I mean, that anastomosis looks so nice. Not a single, when you go back and scope them in 6 weeks' time, you always see your sutures sticking out, and you're like, did I suture like that? Or your staple lines coming through? But this looks like pristine. It's almost like it was made that way.
And with 35 years in the business, we've seen suture bezors and all things from different anastomosis, and kinks from scarring to the just to a absorbable suture, which is kind of ridiculous. But yeah, this looks really nice and pristine, and so there's potentially a future there. I'm trying not to be the old guy that doesn't look at these new technologies as something to go forward. So yeah, thanks for including me.
Oh, absolutely. Thank you for joining us. And look, when we are having fun, we are 5 minutes over. I'm so sorry. I didn't realize that. But thank you all for joining, and I apologize for being late. I tried to drive real fast, but there you go. All right, thank you. We'll see you guys next time. Bye.
Bye.